I'm Robert Childs, anesthesiologist and primary practice in pain medicine. And I'm here today with Doug Johnson, who is engineer practicing in the management of pain. And he has unique insight and understanding of the use of lasers for the treatment of pain and wound healing and associated therapies.
Well, thank you for having me. I appreciate it. I'm looking forward to having this conversation and continuing on some of our other talks we've had.
Yeah, it's very intriguing, and the mind really leaps because this concept of using something to block or decrease pain without sticking a needle or a knife into somebody to grab a nerve fiber is something that's futuresque in a way.
Yeah.
And you seem to really understand that more clearly than most. And what I find a little bit difficult to communicate to others is how light projecting onto the tissue of the body can cause a change in that tissue to decrease pain as it exists, or to decrease pain that might occur in the near future.
Right.
How is this possible?
I know it kind of goes back to that whole thing of, you remember, the original Star Trek where they would shine a laser beam on a tissue and you'd see it miraculously, repair, and they would jump up off the table. So it does have a little bit of that futuristic Star Wars, Star Trek kind of quality with it. But when it comes down to it, the basic biology, we are creatures of light. We respond to light, whether it's going out and tanning and getting vitamin D and this thing. Our bodies are clinically and biologically designed to absorb light. And where it comes into that is why it sounds a little different, is that there are different types of light. Not all light is therapeutic in that same sense. So understanding not only the color of that light, the function of that light, and more importantly, I think when we start talking about, when we're looking at clinical practice, the dose of that light, how much of that light and where should it be applied? Because while we always kind of laugh and say that we, you hear the expression where the sun doesn't shine, unfortunately we can get light into the body. We can get it in there, and there are different wavelengths of light that we can penetrate in through the body. And the goal of that is to make sure we can get a large enough of a dose to get the response we want without heating up the tissue. And that's where this concept of low-level laser therapy or low-level light therapy comes into play. It's figuring out the mechanism of which we can get light into the body without creating heat and stimulating that same response that we were looking for, whether it's depolarizing a nerve or initiating tissue repair.
So, how do you make these calculations in general medicine?
Yeah.
If I'm going to give a drug, antibiotics, say intravenously, I need to calculate exactly how dilute it is, how many milligrams in what volume, and I need to know exactly how fast I can drip the medication in without causing the patient to lose his blood pressure or have a cardiac arrest or something. So how do you do these calculations for light particles, molecules?
Yeah, so it's kind of funny, when you're looking at dosimetry, and it brings it down into what we would call optimization. We have to know what parameters impact that. So different tissue have different absorption spectrum. We know that certain chromophores or light absorbing molecules in the body basically will absorb different colors of light differently than others. So we want to find, first and foremost, what do we want to do in the body? Do we want to stimulate a tissue to get it to heal? Or do we want to maybe inhibit a tissue, let's say a nerve response that may be overactive, or an inflammatory response that may be out of control, a different dose? So when we start looking at that, we have skin pigmentation is always a concern. Body composition is also a concern. And even sometimes we look at age. So we have to take these things kind of into some consideration when we're looking at dose. But when it comes to optimization, you have to do the clinical work. You have to do the laboratory work. Just like any type of medication may have to go through a clinical trial, light does as well. And we have spent quite a bit of that time in our lab looking at the doses. So we've taken low doses, medium doses, and high doses and looked at not just how does that feel? How does this make you feel with the light? We've looked at biological markers within the body, whether it's inflammatory markers, whether it's growth factors or those sort of things, to see what are those doses doing. And there's quite a few systematic reviews and meta-analysis now on the use of light in laser therapy, in particular for pain, which is quite helpful for us. So it gives us some guidelines. Now, unlike medicine, which is a little bit more precise and sometimes in the precision of that, the one thing that's nice about light is there's a little bit more of a sweet spot. There's very difficult ways to overstimulate the tissue. So while we want to make sure we stimulate it appropriately, overstimulation doesn't tend to be nearly as an issue when you're dealing with a drug versus light, because this is a non-invasive, minimal risk type of technology.
Well, if you overstimulate, would you expect a damage to the tissue, like a burn? And would that person who's receiving that excessively large dose feel it and complain?
Yeah, and that's the one thing that comes up with, I think that's interesting about the technology now. So the low-level laser devices are designed to understand, as I mentioned earlier, the skin pigmentation issue. One thing, light generates heat. That's the one thing. That's why it's really nice to be here now. It's nice and warm. You get sunlight. The issue comes in is that if that light doesn't get into the body, it gets trapped into the skin. And this is how we use ablative lasers. We basically are cauterizing, evaporating, or coagulating something to basically open it up. With low-level light therapy, we're not looking to stimulate the skin thermally. So we got to get that light in there. So the low-level laser devices don't heat the skin the same way like a high-powered laser will. Now, when we're doing that, that dose that occurs with the low-level light devices never can become cytotoxic, because it's the addition of that thermal impact from high doses. So when we're talking, patients aren't going to come into contact with this, or even clinicians. Usually it's going to be a physician or with a license to be able to operate a high-powered laser. But these low-level devices, which can be, many of them are actually over-the-counter cleared, they don't have the issue of cytotoxicity, because that non-heating of the skin will prevent the heat shock proteins from being developed, which actually combine with some of the other byproducts from the light, which is usually oxidative stress, which is ROS, reactive oxygen species, which can become cytotoxic. So if we're using low-level devices that don't generate heat, they don't have the same toxicity issues. So patients that may happen to overdo it themselves, because we always have this, if a little's good, a lot is better. If they actually overdo it and give themselves 2 minutes or 4 minutes or 6 minutes, they're not going to cause any tissue damage. But interestingly enough, they also don't get more pain relief either. So it's kind of like, how much ice will you put on a knee? It doesn't matter if you put on one bag or a whole big bag of ice. It's going to be the same impact of it for that. So,
well, that's exactly what I was thinking about what you were saying, was because we know that to interrupt a pain impulse, we're dealing with different size nerve fibers.
Correct.
That have different actual chemical anatomical compositions. Some of them are insulated,
Correct.
With fatty substances. Some of them are just like bare wires, and some of them are actually thick woven cables with a lot of fibrous collagen tissue. And so if I'm going to calculate a dose necessary to block a nerve impulse traveling down one of these different size, wires or cables, how do I approach that calculation? And in concert with that, do I need to consider the wavelength, and do I need to consider the actual power setting, or the pulsation frequency of the light, whether it's constant or pulsating? How do I put all those into the stew there and come up with a good one?
Yeah, it's funny because there's kind of a joke within the light community that we call this the impossible dose. It just sounds like, wow, there's an awful lot of parameters that you have to take into account with that. And one of the nicer things that we've done is when we look at some of the technology, we try to simplify it for people of understanding how do we want to apply that dose. So I think the first thing, we always want to look at the location of what we want to treat. So a superficial nerve versus something that's very deep in the body can be much more challenging, because remember we said we have to get the light through the skin. And not all wavelengths of light are created equal. Like blue light, very, very good. Very, very good for treating different skin and bacterial infections. The problem is our body blocks it almost completely at the surface. So if you don't have an open wound or a way to get that light in the body, it doesn't go in there very well. Red light penetrates a little bit deeper as we start to go in, but red light doesn't tend to have the same effect on pain. Red light tends to be much more a tissue repair type of setting, where it starts to stimulate the process. And when we're dealing with that, we have to be really careful, because some pain have different etiologies, right? Like we know this could be inflammatory pain, and I don't want to increase the amount of inflammation on a patient during that setting. So infrared wavelengths, so wavelengths that are a little bit longer, basically they're kind of invisible to the eye. These tend to work best for pain because they penetrate more deeply in the body and are less affected by the pigmentation of the skin. So we can get those doses in easier. And when we look at these doses, the best thing is we want to make sure we get past that point where we would stimulate that nerve. So looking at that depth, so when we want to treat, let's say maybe a C6 nerve root, we might have to do a treatment that would be 1 to 2 minutes. And we can do this very frequently because we don't have to worry, as I mentioned, with the low-level devices, any issues of cytotoxicity or any damaging thermal effect. But you might do 1 to 2 minutes, and you can do this several times an hour for the patient. So these home devices could allow them to treat themselves when they feel they need it without having any of the potential side effects.
So repeating the dose at that short an interval, less than an hour, is not going to irritate the tissue. It's not going to trigger a pro-inflammatory response or hypermetabolic state. Or
the best thing about that is the dose is cumulative. So as long as you keep the dose in that inhibitory setting, that on that higher side, so that it's not going to stimulate those processes, you actually will cause basically a blocking of the actual mechanism that helps to produce pain inside those nerves. So doing it when you feel pain is actually a great thing, because you can help to prevent that and that blocking of it.
So with pain treatment, there's no contraindication to more not being better. More, if you're treating it more frequently, you're not going to be creating a problem.
Exactly.
Yeah.
So the bigger issue comes in, it's not the frequency that we're going to do it, it's making sure that the device in the dose we're giving is considered a low-level device rather than having something that is producing heat. It's the production of heat along with any of the product that comes out of the laser. So whether it's the energy generation in the cells for that, and the small amount of ROS or reactive oxygen species that's created, we just have to make sure there's no generation of heat and you don't have an issue with cytotoxicity.
Well, if your dose is large enough, is there some generation of heat, such as would be occur with anything in the electromagnetic spectrum?
Absolutely, and that's why I think that's very interesting. So the technology, a lot of what we've researched over the past 7 years has been finding the optimal way to minimize that heat. So I talked about optimization. We had to optimize that dose. No, 1 to 2 minutes will give us the stimulatory dose and kind of be pro-inflammatory to help tissue repair. We know about 3 to 4 minutes of light therapy over basically the neuronal tissue will give us a blockade effect. But the one thing that we've had to do in optimization was finding a way, as we started to do those higher times, those longer treatment times, is to figure out a way to do that, minimize heat aspect. And what we did is we found when we pulse the light, by pulsing the light allows the tissue to thermally relax. So basically, think about it, if you put your hand on a hot stove and pull it back very quickly, there's no transfer of heat. So we can deliver very large doses of light by making sure it remains pulsed so that it doesn't generate any heat within the tissue.
Is the pulsation frequency something that's necessary to be aware of, or is that relevant?
Yeah, absolutely. So when we talk about the pulsation of that, the pulsing of that light works like a camera aperture. It controls the amount of light that's coming in and out of the laser device. So think of the lower pulsing frequencies as being limiting of the light. And this is basically what we might use more for stimulation. We want to kind of control how that dose is being delivered to the tissue. We want to allow it to propagate deeper and kind of hit some of the other structures, whether it's muscle, bone, tendon, or ligament. But when we start to open that aperture up, we get much more light, much more quickly, and you're going to get much more absorption near the superficial tissue structures. So when you're looking basically at your nociceptors, which are mostly primarily in the skin, we want to cover those areas. We want to get a lot of really good real estate. So higher frequencies covering a little bit larger area where you have pain are going to be much more effective for patients than doing a lower dose holding it in one area. It doesn't tend to have that same beneficial effect. It's more stimulatory.
And since the nociceptors are more superficial, then would you be using a shorter wavelength light? Would you go into the blues or the violets, or?
Well, blue light doesn't tend to get almost deep enough. I mean, it really is very almost really superficial. If you're optically transparent, I'm pretty pale skinned. I can get some blue light into my tissue, and this has a really strong vasodilation effect, so basically increasing blood flow to an area. But I really want the photochemical and the photophysical responses. So red light can be very perceptive on pain. It can be very beneficial, but we tend to like infrared. So a lot of what we've done is we've actually combined and mixed different wavelengths. So while I might need a red light wavelength, so kind of a mid-range wavelength for an inflammatory pain, but what about a nociceptive pain where I want to get a photophysical, I want to physically change that structure of that nerve to help block that delivery of the pain signal? I may want infrared. So, and do we really know always where it's split? Is inflammatory pain, is it nociceptive? I mean, you can have inflammatory pain right at a nerve, so which one is it? So a lot of times combining and mixing different wavelengths together can actually give you an even better outcome. So I like personally to kind of combine multiple wavelengths to kind of give me, consider it like broad spectrum, if you will, to give me the best chance of kind of blocking out pain.
Can multiple wavelengths be administered simultaneously through a device? Is there a device that will provide simultaneous administration of multiple frequencies, light frequencies?
Yeah, there's quite a few actually. There's a couple devices on the market. There's some laser devices and some LED devices. The one thing that you won't see are small little point probes, obviously. When you're looking at multiple wavelengths, you're usually talking a little larger clusters, bigger arrays where they have different wavelengths that you can incorporate. So they are commercially available, which is really nice because, as I mentioned, when you're dealing with pain, you want to cover real estate. You want to really cover those areas. And we had a kind of a brief conversation before, is we don't always know where those nerves are coursing through the body. So sometimes having a larger window to make sure you're hitting that target you're really seeking out can be more beneficial.
So, as you alluded to, usually when you have pain on a part of your body, you want to treat that part of the body, you're going to put
Right.
some ice on it if you sprained
Right.
it. And for laser therapy, applying the therapy to the anatomical location, but we also know that with some type of pain, maybe more prolonged chronic pain, or pain from other sources from nerve injury, could be diabetic or other chronic injury, that the source of the pain may be through a nerve that's located not in the area where you're feeling it. So
Right.
if you were going to try to block a nerve impulse on a main nerve trunk, and we know where these nerves
We know
are
where those
located
go.
anatomically, they're very similar in every human in the same location. Can a laser device actually provide enough focused energy to inhibit nerve transmission in a peripheral nerve, like a nerve going down into your foot? There's 5 nerves that innervate the foot. Could I block those nerves? They're just a centimeter under the skin.
Right. And that's one of the best things that we can do is, so when we look at laser dose, we always talk about, so that tissue, let's take the diabetic foot. So they may have some circulatory issues and some things. Well, what if they need healing in that area? Light therapy can do one of two things. It can either stimulate the tissue or inhibit it. It's the same dose. You're doing the same, let's call it the same medicine. So I can't give you just a little bit now and say, oh, I've stimulated it, and then give you a whole lot just a minute later. It doesn't work that way. So it kind of has to be all cumulative together. So what if I want to do stimulation? So let's say that this poor person has some circulatory issues, maybe some wounds and some unhealed ulcerations that they want to do. I don't want to shut that down. I want to help encourage blood flow to that area. So but they don't come to me always for that, right? Like they don't always show up because they've got an ulceration on their foot or they have diabetic neuropathy. They know they've had that, but they're coming because they have pain. So might locally stimulate that area. I want to increase that oxygen that's going to go there, get that nitric oxide release, get better blood flow, oxygenation to that tissue, but I got to manage their pain. So I definitely am going to come up. I want to go most proximal to that before you get an innervation segment break, where I can treat that area and deliver enough energy to get a downstream effect into that nerve. And we have found that the closer you get to the injury, the better off it is. But I can keep coming all the way up until I get to the central nervous system. Many of our clinicians will actually go all the way up into the back of the skull and treat 4 master points at the back of the head, just to hope to stimulate the master computer, as you call it, the brain, to give them some cascade effect for pain relief as well. So we can treat locally, but we feel pain relief can be done quite globally as well.
So for a peripheral nerve, like say a radial nerve in your hand or posterior tibial nerve in the ankle, is that something that can be blocked by the focused application of radiation? Can I provide some anesthesia? Let's say I've got a sore thumb,
Right.
or something like that. Is that?
So the best way that we kind of describe it is that we do analgesia and not necessarily anesthesia. And it's just because of the way that this is really kind of the blocking of the pain signal. So it's not a complete blocking like you might get with a chemical block when you actually go in and possibly inject it or provide mechanical means of blocking that. Like sometimes I know we've seen some cauterization of nerves and things like that where that is pure, anesthesia. But you will get some analgesic effects. And you can do this prior to many procedures. So you can actually do it pre-procedure, you can do it post-procedure. But the benefits tend to be reducing the amount of response that they get, decreasing the sensitivity that they have. And a lot of times patients, when they get even just one dose, can see significant drops in their pain.
So if I was going to have an operation, prior to the operation, let's see, I was going to have a total knee replacement, which is very painful. And I know my older friends of football players, they all have total knees, and they all complain bitterly. Are you saying that there's some data available to demonstrate that treating the surgical site before the surgery is going to decrease the inflammatory response or the pain after the surgery? And is there any data also on the healing effect pre-surgical?
Yeah, so we were talking a little bit about, like, we call it a lot of times prehab. They get to spend a few times with a therapist or a clinician before. And part of that is to start to help using light to modulate the inflammatory process that's just been running amok. I mean, these poor people have just, you look at their biomarkers and they're just off the charts. I mean, some of these, like the TNF alpha, which is really one of the worst markers, you see these are insanely high before they go in. So we want to kind of modulate that. We find patients that go in and do light therapy 1 to 2 weeks. They get a device, they take it home before the procedure. They do much better. They ambulate much faster. They have less complications during the surgery, and they recover faster. They like the way the scars look a little better too, obviously, because it does have some stimulation to the skin. But one of the interesting studies that we had actually done was looking at total hip replacements. And we did it afterwards. They went in and we measured their blood markers before they had their surgery, and then we looked at them immediately after they came out of surgery. And we found that the TNF alpha marker levels, basically their inflammatory marker level, was less after surgery than it was before they even had the surgery. Mm-hmm. It modulated their pain for a full 24 hours. The unfortunate placebo group wanted medication immediately after they came out of sedation, whereas the light group didn't really request medication. We found that they ambulated faster in the follow-up and had less complications. So definitely some better aspects of looking at not only how you can control it, but it's a way of maybe we can look at some complementary ways to manage pain.
Well, in those cases of the hip, I mean, this is very intriguing, was the field of therapy preoperatively just the surgical incision location, or was it also the joint, the actual hip joint and capsule?
So they did both. So they did 5 locations around. So they did directly over the incision, and then 4 locations, anterior, posterior, superior, and inferior, around the joint as well. And the therapy was very easy to do. It was close to about maybe 20 minutes worth of light therapy that they did. And these people had pain block. They had good pain control for almost 24 hours. And this is a procedure that has so much catastrophizing fear for patients. They just don't want to hear their friend always tells them that. They always have that one friend that has that bad story about how they had their hip done, right? So what a great way to say you might have something that could be beneficial, to you.
Very interesting. Well, thank you very much for taking the time to bring us up to the current understanding in this area.
Oh, well, thank you very much for having me. I appreciate it.
Visit quantumuniversity.com for more information.